Hello, my name is Ashley Ali, and I'm the Director of Education and Training with Snoasis Medical. On behalf of Snoasis Medical, we would like to thank the AO attendees for joining us this evening for a lecture using BioXclude for minimally invasive dental implant surgery. We will be having a collaborative discussion with Dr. Dan Cullum, an oral surgeon from Idaho, as well as Dr. Michael Block, an oral surgeon from Louisiana. Dr. Cullum, please explain your thoughts on the use of BioXclude in oral surgery.
Well, thanks, Ashley. It's great to be with you today. And in my practice, my thoughts are that I want to be able to have a product that I can use to upregulate and enhance wound healing. And I need something that's off the shelf, that's easy to use. And BioXclude is an immunoprivileged material. It's anti-inflammatory, it's antibacterial, and it also helps with accelerated wound healing. And so it's a unique product in that it's a barrier and a growth factor carrier all in the product.
Thank you so much for that. That makes a lot of sense, and I think those are really important attributes to point out. Dr. Block, in your practice, which applications do you choose for BioXclude and why?
Well, there's a variety of things that I like about this material, and I appreciate the opportunity to share this podium with Dan. He's one of my mentors, so I love it. The material is been out for a while. It's not new, which is a good thing for me as a clinician, because it's something that's been out for a long time. It's been used in the medical arena for almost a couple decades, and the science behind it is superb. So I have no issues using it anywhere I need to. So that's the first thing. The donors are screened. Everything is done right. There's the tissues are quarantined, and that's of course a good term nowadays. And everything is screened, so it's a very safe material, well made, and the manufacturing is superb. It's very clean, so I like it for a lot of the cleanliness and the safety aspects and the history of it. It's not a material that just somebody came up with a couple weeks ago. It's been out there for decades, so I really like it. And what I find really important with it is knowing how it works, or knowing what makes it special. And it does come from placenta. There is an amniotic and a chorionic layer there within the placenta. And what's interesting is if you look at any of these diagrams that are available on the BioXclude and Snoasis websites, you'll see that there's an epithelium lining over it. And that's really key, because what they do when they process it, and this is why I like the material so much, is the epithelial layer, as you see on the left, that pinkish area is removed. And then when that's removed, the other two layers and the spongy layer is removed. And then you put all these things together and you end up with an amniotic-chorionic layer that doesn't have the intermediate areas or the epithelial areas. And if you look at the chorion layer, you see it's thick, so it's going to have more growth factors to it. So I really like that material. The membrane of the amniotic layer is exposed, which is key, and that to me makes it work. And the reason I'm explaining this before I talk about the applications is this makes it work. The membrane actually has a tremendous amount of growth factors on it, and it facilitates cellular migration, so cells love to crawl over it, and they crawl over it as they heal. And as they do that, they hit the growth factors, and they just explode. The soft tissue healing with it is phenomenal. And you can see this is a Mohs surgery. This is out of a text, and you can see from the left to the right the healing, and it's they call it EpiFix, which is the dermatology version of BioXclude. So you see the healing; it's phenomenal, and so it's been around for a while. The other thing that I like about it is the antimicrobial aspects, and you can see the zone of inhibition when it's placed on a disc and then impregnated with bacteria. And it does this much better than other materials. The other materials don't have this antimicrobial effect. So the antimicrobial effect I find in an extraction site, some of these extraction sites that I take teeth out are not necessarily healthy. Many of the ones I take are just not healthy at all. So there's
Sure.
got to be some bacteria floating around in there. But this really helps it. So I'm amazed at the antimicrobial part of this as well as the growth factors. And that's really what I do with it. Now I'll show you some applications as we go along, but I don't know if Dan had anything to add to that.
No, I agree, Mike.
So when I'm looking at applications, so where do I use it? So this is just me. Now I'm in private practice, and I work hard, and I do a lot of dental alveolar, a lot of implants, and I take out a lot of teeth, and I'm going to take out the teeth and prepare them for implants down the road. So this is a classic case. This is an anterior case. So I'm going to take the tooth out, you see on the left. I'm going to put some graft material in it, whatever I choose that day. And then I put the BioXclude over it, and I just put a little suture over it. And I suture it, the sutures run over the membrane, so you can barely see the membrane, but it's in there. And maybe Dan will show some videos of it later. So, but it's in there, and you just tuck it underneath the edges, and you over sew it, and you're done. It's and the next thing you know, 2 weeks later, it's completely epithelialized. So I use it for that, and sometimes I find some of these wounds that have a lot of infection or other problems, they're not that easy to close. There's a molar site, a maxillary molar site, which I find hard sometimes to bring the palatal tissue all the way over. So you can see the membrane there. It's a little folded over. I probably could have had a little smoother, but it's again, it's just oversewn with, and I use chromic suture. That's all I use. And then here, this is one that's a little cleaner. So I think you'll like this one better. This, but you see the tooth has been removed, the graft has been placed, and then on the right side you see the membrane is in there and it's tucked in. And I'll use a 12 by 12 membrane on this, and I'll fold it a little bit if I need to, or just tuck it underneath it, or I use an 8 by 8. I use those. Those are my main sizes that I particularly use. And I'll put the suture in it like that, and 2 weeks later when the patient comes back, it's almost completely epithelialized. And I just don't see that if I use another material, so to speak. So, and then I'll just show you this case real quick. This is a disaster case. This guy had an implant placed in the left central incisor site by somebody who shouldn't have been doing implants. I just leave it like that. And then the implant, one implant failed. Then he put a graft in, and then he put an implant in, and then it got a little loose. So he went in and opened it up again, and he put another graft in, and so that implant is mobile, and he's got gingival recession. So the reason I'm showing you this case is what I did with it. So I opened it up and took out the teeth, took out the implants, and then I came back and I grafted it. This is LPRF, so I put this over it because I like using that. I like that, and then sometimes I put the BioXclude over it. But what I did on this case was when I closed it, instead of pulling the keratinized gingiva over the whole site and closing it primarily, in the extraction sites, which are going to eventually get implants, I put the BioXclude membrane. And so I use that instead of needing to do primary closure, and that keeps my band of keratinized tissue intact. And by doing that, when I come back to it, this is at day 17. You can see the epithelium is pretty well formed. It's got a little exposure to the graft here and there. But then as he comes along, if you look at that picture in the lower right, you can see that the tissue there is really well formed, and we've got some generation of new tissue there. He's got a couple areas of some graft that I picked out, just some loose graft, but this is a huge graft that we did. And I think the BioXclude membrane really helped in the soft tissue healing in those sites. And he's due to have his implants placed on Monday, as a matter of fact. So this is kind of like where I like to use it. That's my main use.
That's great. That's really a great explanation. And it sounds like you really feel confident that BioXclude is both safe and effective, with a wonderful explanation and then also demonstration clinically what that looks like for you. Dr. Cullum, what about you in your practice? What applications are you using BioXclude for?
Next slide, Mike. I use it, the predominant areas are like Mike described, mostly around extraction sites to do open healing when we don't have to do primary closure. And here's an example at an extraction site on adjacent teeth. This site was grafted with xenograft to maintain dimension, and then covered with an 8 by 8 BioXclude over each site, and it's sutured inversely with upside down figure 8s that we'll show toward the end of the talk. And next slide, please, Mike. And here you can see the slide at, on the left at about 9 to 10 days, and at 20 days on the right, where the lateral is completely epithelialized and matured, and the central is just finishing closure. Next slide, please. I use it a lot around immediate implants. Next slide, please. So in that kind of application, here's a case where we've got 2 extraction sites and an implant. Next slide, please. And you can see the implant position, and now we're going to graft it on the implant on the buccal aspect. Next slide, please, Mike. And so now we place it, and next slide. The left side will show an example of a video placing it around a single tooth immediate site. And so in this situation, I trim it about 30% oversize, and here we tuck it in on the buccal aspect, and then we'll take a piece and place it and tuck it in around the palatal. You can see the staff person's wetting it with sterile water, and then we tuck it in position, and then we do the inverse sutures through the palate first. Here is with 5-O-glycolon, which is what I use most of the time. And then we'll come back out through the buccal and tie it. And it's slightly mesial to the line angle of the tooth, so that it acts like a bungee cord holding the tarp down on the back of your pickup when you're taking a load to the dump. So it keeps it in good position. Next slide, Mike. And so here we can see the immediate post-op. On the right-hand side is with chromic. I find chromic works great on smaller wounds. On bigger ones, I tend to use glycolon or PTFE. And in this case, you can see grafting on either side and then grafting around the immediate implant. Next slide, Mike. Here's the patient after early healing, and it just epithelializes and really matures nice and quickly. So it's a real win for the patient. Go ahead. And now if we look at this patient after healing and provisionals on this case, you can see the 2 canines have both been managed with a similar technique, and you can see the volume of bone and the thickness of the soft tissue in the tissue form surface. So very nice way to manage patients. Next, please. Here we can see another patient that's got immediate and a combination of immediate and socket grafting. And next slide, please. She's losing these molars and the premolar. Here we use dynamic navigation to develop the site and an osteotome for a small floor elevation. Next slide. And now we position the implants, do our normal testing. And on the right-hand side of the screen, you can see the gap on the molar site to the implant collar and to the buccal. Next slide, please. And here you can see again some slightly oversized trim pieces, and they're placed around the immediate sites. Next slide. And here's the patient finished with chromic suturing. And on the right image, you can see on the molar that there is a large buccal void and a vertical soft tissue defect, and the material has been placed right onto the side of the healing abutment. So the BioXclude lets you tack it, and it'll stick and it'll adhere. Next slide, please. So here's a patient after 4 months healing, and that soft tissue and bone have healed right up to the mesiobuccal margin where we had that significant hard and soft tissue defect. Next slide, please. So in this composite starting on the left, you can see the defect with the healing abutment in position. The next image over, you can see where the BioXclude has been placed on top of the graft up to the side of the healing abutment. The central image now, you can see where the tissue is healed up to the height of the 3mm healing abutment compared to the far left image. The next image is the same day. A wider, taller healing abutment was placed to begin tissue sculpting. And on the far right side, you can see the excess of very nice cellular tissue in that area that had a huge bone and soft tissue defect. So this gingival response to Amnion-Chorion is very favorable. Next slide.
Thank you, Dr. Cullum. That's a great step-by-step explanation of both application and some good handling pearls, in my opinion. Thank you for that. Dr. Block, what do you think the advantages of using BioXclude in your practice are?
Well, in my practice, the main thing is the consistency and the soft tissue response. It's again, I go back to the material has been out and has been used for a variety of medical applications, as you see in this slide. So it's been around, and it's phenomenal response. You know, you've got this being used in general surgery for diabetic ulcer treatments, as you saw the Mohs surgery, and it works. And the reason it works is because of these things. The membrane, the basement membrane, has on it growth factors. That's where it is, and if you it has those growth factors in with the baby are very important for their generation and generation of the placenta. So these growth factors are sort of glued on it. I figure they're glued on, almost like a barnacle on a boat. I don't know if that's the right term from Snoasis, but they're glued on. And
good analogy.
It's an interesting analogy. Well, down Louisiana, you know, we have that, you know, this. So please excuse me, Rob, for that one. So anyway, the growth factors are there, and they don't elute like they would on other materials. Other clots, not other clots, but clots or other things like that. They tend to elute their factors from the growth from the serum and the different clotting aspects of it. But these are stuck on there. So when the cells are growing across, they meet up with those growth factors, and there's this very slow elution on it. And I think that's the key, is that the growth factors are so accessible to these cells as they're going across. And there's a lot of different ones, a lot of platelet-derived growth factors, TGF, EGF, and it goes on. And, you know, and now the interesting thing is the chorion layer is thicker, and it's a matter of mass that has more of the factors in it. So you have more of the growth factors in the chorion layer, which is the deeper layer. So you're going to have a sort of a dual elution on this as the material is dissolved over time, over a period of 7 to 10 days. So that you have a lot of regenerative factors that are being made available to the tissue, and you can see it's VEGF, it's the PDGFs, it's all there. And that's what really makes the soft tissue explosion occur, and that's where we get this epithelialization and the healing response that is so prominent. So these are the reasons, and this is the one nice thing about this material is the science behind it. As if other people want to see it, they can just go to your website or contact you all, and you have great science behind it, which I think is a really tribute to the material. Because there's so many materials that we get marketed that are just not like that, and this one has science, and these are very consistent growth factor assays that have been proven and time again. So it's been confirmed. So this is why I find that I like using material, and I think this is the advantage of this material over other materials, because the other materials don't have those growth factors adherent to a membrane that stays there in place while the soft tissue is healing. And once you get soft tissue healing, we know surgically, anything underneath it's going to do better. If you don't get the soft tissue healing, you're stuck. It's just not going to work. So a lot of times if we have friable tissue or tissue that's not good, we'll take out the insulting agent, the tooth or the root or the implant or whatever, let it heal and then come back and graft it. But we need some tissue that's healthy, and this really does make a difference. And of course the antibacterial aspect of it, as I mentioned earlier, is key. Because a lot of our cases, as I showed you, we're taking out teeth. Dan showed you too. We're taking out teeth that have different bone defects, and you want to have these implants work perfectly, and patients are expecting great results from us. So this really adds to the whole thing. So I just find that it's minimally invasive. I mean, you can take the tooth out, put the graft in, put the membrane in it, suture it up. I mean, I use a simpler suture technique just because that's what I'm used to doing. And maybe I'm a little more hard-headed to learn something new. I guess I need to learn that new technique. But I find it once you secure it, and I've been putting a lot of grafts in, a lot of membranes over things, and I just oversew it with a sort of a similar type, not a mattress suture, but I just oversew it, and it bolsters it in. It's more like a bolster type approach, and I find it works fine in my hands. And then, but again, by 2 weeks you can see the results. So it's super. We don't use any fancy things. My post-op patients are just using diluted salt water. That's all they use. And there's regular antibiotics. So there's nearly nothing fancy with the material. In fact, we don't want to do anything fancy with it. We just want to let nature do its work. So that's kind of like what I do. When you look at the different clinical comparisons with socket grafting, I don't know if Dan has some comments on this slide, but it's really in this kind of work that's been done, and this was reported in 2017. The shrinkage of the ridge is a little bit less with it. The whole thing, the pain levels are a little different. It just works. I mean, the stuff just works. Soft tissue wise, it just really works. So this is where I'm impressed with it, is the early phase of healing. I think that's a key thing. This is from Dr. Del Vecchio, and Tony. These are his slides. I mean, and he was kind enough to loan them to everybody. 72 hours a week in 2 weeks, and you can see it's healed up. And this is what we see too. So at 2 weeks, you really have an epithelial wound. I showed a case the other day. I said, "This is 2 weeks," and he went, "What?" He couldn't believe it. His mouth was wide open. He just couldn't believe that the socket that he had seen me treat 2 weeks ago, that he came back. He's there on Mondays with me, and I said, "Here's the patient post-op. Take a look." And he went, "That the same case?" I said, "Yeah." He said, "That's amazing." I said, "That's the material." And he went, "Wow." And he says, "I got to get some at the school." I said, "You do?" That's right. So he loves it. So the early healing. This is from another gentleman, another doctor in Texas, and he was kind enough to share these slides. See, everyone's so excited about it. They take pictures and they share the slides because they just love the material. They want everybody to use it, and it's just very good healing up front. So that's why I like to use it. That's the main advantage. The growth factors really help it. So hope that helped you.
Thank you, Dr. Block. That's a great overview of some of those inherent biological attributes that BioXclude offers. Dr. Cullum, same question. Do you have any additional advantages that you find with BioXclude?
Yeah, next slide, please, Mike. The thing that I find, like Mike talked about, a lot of times the wounds that we have are compromised. So they're previously endo-treated several times. They've had apicoectomies, fractures, and then lesions. And so the wound sites are compromised. And when we're trying to get tissue regeneration with both hard and soft tissue, being able to make use of the tissue regeneration triangle and using Amnion-Chorion or BioXclude in place of other agents that are a lot more expensive or don't have as long of a half-life, or tissue diffusion and disbursement, as Mike talked about. So my thing is wanting to be sure that we can predictably regenerate that, especially in compromised folks with systemic disease, diabetes, or chronic steroids. So being able to upregulate wound healing for compromised sites or patients is huge. Next, please. The other thing that I wanted to point out, in addition to what Mike had said, was there is a split mouth study in J. Perio from 2010 that compared right side and left side, or bilateral cases with single implants, and found that the single implants that were done with BioXclude had a huge difference in pain profile and inflammation. So there's another set of data that really does show us the advantages from preventing inflammation and pain in folks.
Thank you, Dr. Cullum. Those are additional points that are very important. I'm glad you added those in. Dr. Block, how do you manage and suture the wounds when using BioXclude?
Well, a couple of things that I do, and I'll just leave this slide on as I talk. So I take the tooth out, and typically I'll have made a small incision, or maybe no incisions at all. And I'll put the graft in, and then I'll tuck the BioXclude, the membrane. I'll take the membrane out of the pack, and sometimes I have to cut the pack to take it out. I take it out, and there's a smiley face, which I always smile at. I don't know why, but it just makes me smile. And I try to take the size that will fit the site. I try not to overdo it, but typically sometimes they're a little larger than the site. So instead of trimming it, I just fold it. I just take and fold it over a little cotton tip, little cotton forceps, fold it and squeeze it, and then I just put that inside, put a little water on it, and there it is. And I tuck it underneath the edges of the wound. Now, when I do that and I have to suture it, I put a little Hirschfeld elevator, or one of those small elevators like Dan was using, underneath it, and I pass the suture underneath it. I pass the suture so that the metal part of the instrument is holding it down. And that is an easy way for me not to spear the membrane. and then I'll pull it through carefully, and I'll hold it down with the metal instrument. It's a little Hirschfeld number 20 elevator that I like using, or number 7. And then I'll go and put the palatal one in, and I'll come back and do that repeatedly. And if I'm careful manipulating that with the metal instrument to hold it in position, it's really easy to handle. It doesn't move around too much. It doesn't come out easy unless you spear it with the suture. Now, if you do spear it with the suture, it's not a problem. And if I need to, I could even take the suture and go through it into the palate and suture and tack it down. I do that several times. I do that quite an often amount of time. So I just find it pretty easy to handle. It's no big deal. It really isn't. It's just, you just put it in there and you put a little saline on it, and it just flattens out. The first time you use it, you have to realize you have to follow the instructions on how to do it. It's a good idea to actually read the instructions on how to handle it, because the saline in the water is different than what you may. You don't want to be having a real high-speed suction on it, because you'll suck it up, and you don't want to do that, because you can't get it after that. It's gone. So you want to be a little gentle. I tend to take a piece of gauze, a wet piece of gauze, and dab on it, not a dry gauze.
Yeah.
I find that works really well too. Just if I have a little extra fluid in the socket. Very simple techniques. I don't get too aggressive with it. I don't need to. It's really easy to use. I mean, it doesn't take me any extra time to put it in. So I just find it really simple. So I don't have any major secrets to it. I liked what Dan was using with his little instruments that he got. Those are nice little instruments to pack it in, and I use something similar. Yeah, that's what I do. Dan, what do you do?
Next slide, Mike. I use sort of like this suturing technique where we pierce the lingual or the palatal and then come across and do a horizontal figure 8. In a lot of molars, I do a single inverted and then a figure 8. And if we go to the next slide, we've got a video here. So there's the untrimmed piece of BioXclude for a second molar site. And we wet it with sterile water. And now we're just tucking the margins in around the edge. And of course, you've got to be careful not to let your staff suck it up. It's too expensive. And now we want to take it past an initial palatal pass. And here we're using PTFE. So I tend to use PTFE and glycolon, mostly glycolon now. And so we tie that anterior suture, and then we'll take and pass an additional suture on the palate posteriorly, and then through the buccal. So there'll be a figure 8, and now we'll tie it off. Sorry, the video is a little slow on my end. So we'll tie it off here, and now you can see the immediate post-op. So there's a single figure 8 and a double figure 8, and here it is after 7 days of healing. Next slide. And here's an example of a GBR with the implant placement, and I've just slightly trimmed it oversized so that we can get it into the interproximal areas. And we basically lay it into position with dry instruments, then hit it with the sterile water and tuck it into position. In this case, we have the extra piece we took out that we're going to stick into the anterior as an extra dose of growth factors on that interproximal bone where there was a bit of a defect. And now we'll take and suture it with, in this case, a mesial-based rotational finger flap to close it over and around the implant. And it works out very nicely. So I think the initial challenges that folks have is not reading the package, like Mike said, and making sure that your instrument's in dry and clean when you first pick it up. And then when you manipulate it, you do it with wet instruments with sterile water or saline. Next slide, please.
Perfect. Thank you, Dr. Cullum. That's a great few tips there again. Dr. Block, have you noticed when you're bringing post-ops back that you have any concern if the BioXclude is still in place, if it's been dislodged?
Well, I see my patients at 2 weeks, and if they did it look like this slide right there, I'm thinking maybe it went away. It can certainly do that if somebody eats something sticky or maybe plays with it or irrigates the area out. You still do get the initial couple of days of soft tissue healing. So even though it may not be there, it looks pretty healthy to me. But that doesn't happen too often. I do have some patients that are very, very compulsive cleaners in their mouth, and they
Yeah.
rinse really hard, and I have to identify them early. And sometimes they come back and some of the graft's gone, and I tell them that I'm so proud of the way they take care of their mouths, but they can be a little less aggressive, maybe a little more gentle.
Yeah.
And but that happens to everybody, and that does happen. If I recognize that early enough, and normally I tell everybody, just leave it alone, don't mess with it. Just use a little diluted salt water. Don't brush your gums. Just brush your teeth. Don't use an electric toothbrush. Leave it alone. They do great. So I have to make sure. And our assistants, that's actually on our post-op instruction sheet. And our assistants go over that with them on a consultation. And they also go over it again after we're done with the surgery. But some of them have had some Valium or some other medicines, and they may forget everything you tell them. So I call them at night and say, now, don't forget, you're not supposed to be too aggressive. And they say, oh, no, I'm doing great. I'm doing fine. I had this and this and this and this. So they're doing fine. That may happen. We haven't found it to be a big deal. It doesn't happen any more often than with any other material. You know, a piece of collagen that's stuck in there as a plug and oversewn, that leaves the patient pretty early. But so I haven't seen anything adverse on this at all like that. No.
Do you have anything to add, Dr. Cullum?
Next slide. You know, I think that a lot of times the material is so thin that the graft material can just transluce through it. It looks like it's not there, but it's most of the time still there. And this image just shows different, you know, stages of healing in different kind of wounds. So I think that the big thing is that there's no inflammation and the wounds look good and the patients don't have any pain. Next slide.
Would you like to go over briefly your post-operative instructions?
Sure. What's different about this material than most, next slide please, is that it doesn't like things. It's a real particular play with itself kind of material. So all the things that we're used to doing, for example, you know, more rinsing like Mike talked about, the vigorous people can pull it out even from a narrow extraction site gap, but it is antibacterial and it does improve it. So basically we recommend just tap water only for 7 to 10 days, depending on how big the wound is. So smaller immediate wounds where the gap is pretty small, 5 to 7 days, and a full socket molar, 10 days. Next slide, please. The important thing is that any positively charged ions or any surface active agents like peroxide or chlorhexidine or alcohol is important. So in New Orleans especially, you don't want people going home drinking bourbon and poisoning the membrane. And I find a glass of wine's okay, doesn't seem to bother too much, but even if they get too concentrated with the salt water, that can be a risk. So I just tend to tell them to use tap water only, and I don't let them go back to chlorhexidine. I use it preoperatively for 3 days to lower the bug count in the mouth, but I don't use it postoperatively. Next slide. The one thing just for being careful with stuff, if you have a patient that has anaphylaxis possibilities to aminoglycoside antibiotics, there could be trace amounts left over from processing. So that's really the only thing that you need to keep in the back of your mind. I've never had a problem with it. And it's just something for full disclosure to folks to know if they have somebody that has a significant allergy to aminoglycosides.
Thank you. Perfect. Well, I think that gives us a great overview from the two of you. Thank you both for doing this for us. Are there any closing statements either of you would like to make, or extra points you didn't get to hit?
No, my main point is that I think the clinicians using this would benefit from reading your scientific literature, because it'll give them a tremendous confidence using the material. And the growth factors and the antimicrobial. The more they know about the material, they know why it works. If you know why something works, then you can use it in your practice routinely. So I applaud your company for having so much of that science available to everybody. So thank you.
Thank you.
Yeah, I'm thrilled to use it and to work with the folks at Snoasis. They're a great group of people, and they're science and outcome focused. And I find that it's a huge adjunct to taking care of patients, especially when we're trying to do minimally invasive procedures and reduce pain and discomfort for all the reasons that Mike's just talked about. So thank you very much.
Thank you so much, Drs. Block and Cullum. We will have the ability to watch this again with a link that will be provided to anyone that would like to review this once again. So thank you for attending.
Thank you. Have a great day.
Thanks for having us.
Thank you both.
Thank you all.